following is a conversation with Professor Max Nieuwdorp, a professor at the Amsterdam Medical Centre with a particular interest in hormones, the gut microbiome, and how changing the microbiome can have an impact on metabolic diseases such as diabetes, obesity, and metabolic syndrome. I've been excited about getting Max on the podcast for a long time. He has been trailblazing and pioneering this field for well over a decade now and has his name attached to some of the highest profile publications so far. Max has been involved in FMT studies in C. difficile infection, but also in FMT studies in obesity and metabolic syndrome. So if you're interested in how the microbiome may be involved in weight loss, weight gain, hormone regulation, including insulin, this will be a great episode for you. He's also the author of a book, The Power of Hormones. And within this conversation, we also explored the latest craze in these anti-obesity weight loss drugs, the GLP-1 agonists. Max gives us his views and perspectives on those drugs and what the future looks like for patients who are obese. We touched on what does the future look like for microbiome research. I learned a heck of a lot from this conversation, and I'm sure you will too. Please like and subscribe if you haven't already. Send in any suggestions if you have them. I really appreciate you listening and supporting the podcast. It's been going almost 3 years now, which is kind of crazy. But consistency is key. Cadence and consistency. And that's what we're doing here. Thank you for your interest in gut health. Thank you for your interest in microbiome science. This is Inside Matters. My name is Dr. James McIlroy. I really hope you enjoy it. Max, thank you very much for joining me on Inside Matters. Why don't we start with, how did you first get interested in the connection between the microbiome, gut health, and the metabolism?
Yeah. It was in 2007 when I was doing a postdoc at UCSD. So I'm trained as a MD and then did a PhD in the University of Amsterdam on diabetes. It had nothing to do with the microbiome, just vascular complications of diabetes. And then through a grant of the Dutch government, I was allowed to go to UCSD. And by that time, I was working a little bit on the intestine and the mucus layer and looking at which sugar chains on the epithelial layer would give bacteria some feeding, and which sugar chains would really be not so good for the bacteria. And it was a glycobiology postdoc. And at that time, there was a paper coming out of Jeffrey Gordon that in Nature, and he said, I think the microbiome is going to be very important. And interestingly or not, in the year before I did my postdoc, we did first pilot FMT in patient with C. diff, because I was a first year resident. There was no cure. This lady was already there for a year in the hospital. And then I said, well, I Googled a little bit, can we do a fecal transplant? It has been done in Norway. And my supervisor said, sure, it's a good idea. So we gave that fecal transplant, and the lady basically was cured and could spend her last few months with her partner who had disseminated cancer. So that showed me the power of the microbiome, but we had no idea how to measure microbes. We basically didn't know what we were doing, like the other people that were doing these FMTs. We just did it. And then by reading Jeffrey Gordon's paper, I thought this might be interesting, but I was only working in the C. diff field. But then, and this is really like an epiphany a little bit. So I was changed, and my daughter was 6 months old. She was with us in the US, and of course, and then I changed her diaper, and I was thinking, she now is eating normal food, not only milk anymore. What if we could use that stool to transplant into obese or diabetic patients? That's how it went.
Wow.
And I thought, well, putting baby stool into adults is not a good idea, but maybe from lean to healthy. And that's where it started.
Interesting.
So it's really, I think it's serendipity a little bit, because if I would not have read that paper of Jeffrey Gordon, I never would have thought that you could measure it, because I was just a clinician, right? I just thought you give stool, you look at the outcome, it's fine. But that you could really delve into it, Yeah, that was amazing. And this is only 17 years ago. So if you imagine how much it progressed, it is amazing. But it's serendipity. Yeah.
That's an amazing story. And it would be, I think, excellent now to hear about how the state of the art has changed over the course of the last 17 years and work in the research that you've been involved with.
So that I think I've also when I wrote my book, I thought about this because there's a few chapters on the microbiome and metabolism and health and disease. So I think what really revolutionized the field is the cohorts, which because when you look at the first papers, also Frederick Beckett and others, there's 100 people in a cohort. They find some associations, then they merge all these cohorts. They don't see the associations anymore. Turns out they didn't correct for medication, diet. All this stuff came out, which when with let's say in Dutch you would say normal clear thinking, you would have predicted it, but everybody was so excited that we ran into that kind of underpowered studies. But the large studies that came out, American Gut, but also here in Amsterdam, the Helios, the Lifelines, other cohorts, they are really showing that there is a real predictive, correlative causation effect of the microbiome in human disease. So that I thought was very interesting. That's more technical in terms of sample size. The FMT took the shortcut because with the FMT we were able to just show the magnitude of effect. So my feeling now 17 years later is microbiome is important in obesity, but it's much more important in cancer and autoimmune diseases. And IBD, it's a little bit in the middle. So I think we learned a little bit what the power is of the microbiome while not really fully understanding what this intervention does. And then the technique in terms of sequencing went ballistic, the multi-omics kind of bioinformatics, the depth of sequencing going from when we started, we only could study families of bacteria. Now we can so go to strains and look which strains was coming from the patient, which strain is from the donor. So that is amazing, I would say. Yeah, and then finally, that still many of these studies could have been done in academia, right? Because usually to make a product or to do an intervention in humans with let's say some medication kind of thing, it would cost a lot of money. But apparently there was this gap or window where we could really do this. So yeah, I'm excited to see the outcomes. I'm also a little bit more down to earth in the effect size of the biome. It's really the oil tanker that goes from left to right in years and not in days.
Interesting.
But I think our biggest thing that we have done is that we now have these FMT capsules and we have these synthetic consortia, and I'm really expecting a lot from that in terms of effect size and stuff. Yeah.
Because one of the things I'd love to unpack that I thought was really interesting there was you mentioned that you think that for cancer and autoimmune disease, the microbiome is fundamental, but maybe less so for obesity and GI. And one of the big questions I had for you, which I ask a lot on this podcast, is the microbiome controlling our weight? And you're the expert. So
yeah, so it does. But you know, when we started the field, we thought if you do an FMT, people start losing weight. But of course we didn't see it, but we hypothesized on it. And I think it's a little bit overambitious to think that usually people gain weight by half a kilo, 400 grams per year. But and losing weight can be faster, but you really need to do something for that. So I think the biome, it is a combination with your diet and your genes, that's for sure. And if you have, and I think if you eat every day a specific compound that makes you insulin resistant or gives because it's all about inflammation. This is not about only eating calories. It's also a combination of how can your body ferment and get rid of the food compounds that it's given by eating, and how can it use the valuable sources for energy and for muscle. And I think the ethanol story, which we might touch upon as well, shows that there is a big power in terms of production from the microbiome from our food into complication of obesity like fatty liver.
Yeah.
So we're talking about big amounts of stuff produced by the microbiome. And we have only there studied ethanol produced from the gut, but you can also imagine it's compounds that make you want to eat more or make you want to eat less.
Makes sense.
So I think it is there, but once again, not as like a therapy weight losing drug that works within waste. If you can modify the biome for weight reducing effect, you will have to wait like also month, 3 years. So you have to keep pushing it into one direction. Yeah.
Because one of the topics for later is the GLP-1 craze, which I'd love to kick your brains on. But just going back to the microbiome piece then, just for the listener, has anyone ever replicated the Jeffrey Gordon work where you move microbiota from a lean animal or human into a more overweight animal and human, and you see these benefits? Because, you know,
I'm not a mouse expert, so that is I do know that because he has been studying, of course, the effect on weight,
yes,
less on insulin sensitivity. So I'm not aware of any of those studies, but I do know that the opposite, giving stool from an obese person to a mouse and make the mouse obese, has been reproduced many times. Okay. So, and I think we have done this first FMT showing temporary effect on insulin sensitivity. 4 other trials have been done, 3 have been reproducing it. So I think there is some therapeutic effect in the microbiome from healthy subjects if you give it to obese subjects, whether you're an Asian or whatever, but it's also temporary. And that is, I think, where the next generation of scientists should look. How can we lock in that beneficial effect of donor microbes into the existing environment of a gut of a patient with a fatty liver or obesity? That is, I think, the $1 million question. You could think about antibiotics to open it up. You could think about whatever, but we still haven't solved that. But I think what Gordon showed, and I think that's Frederick Beckett's work, that you can modify adipose tissue, and it's easier for the microbiome to make you obese than to make you lean. That's interesting. I think, what we see.
That's interesting. Why do you think that might be, that it seems to be one way but not the other?
I think it's easier to gain weight than to lose weight. That's our physiology. We have this called set point weight. So everybody has a weight that the body likes, and that's genetic, it's environmental, and then especially in this, it's also historical. So we are all descendants of people that 100, 200, 300,000 years ago survived famine, right? So that's what it is. So we are trained to store, our body is made to store energy in fat. That's why that's our genes. And the microbiome has evolved with it. That's the way I see it. But the microbiome is selfish, so it just thinks of itself. But I also think we're underestimating that the microbiome, not by going into the bloodstream, but by metabolites, is talking to our brain. Good brain axis is there in humans. It's just less clear than in animals. And I think that's a very important point I wanted to make, because you said, what are the biggest breakthroughs? We've also shown the microbiome can do miracles in animals, and it doesn't work as good in humans.
Yeah.
Mouse is not a human. We can learn. And the basic principles are there. But to answer your question, I think the biome evolved with our genes to store fat and energy in an efficient way. And I think the biome is also, my prediction is, it changed a lot in the last 70 years because it adapted to the way we eat our food. And then it made some groups blossom and some groups die.
That makes sense. Just this concept of the set point weight.
Yeah. Is
that genetically predetermined then, essentially? And therefore, if your parents are overweight, you're more likely to be overweight. How is obesity genetic?
Obesity is certainly genetic. Obesity is also well, it's a very good question, because how do we define obesity? The biggest thing that we're now running across, I just became director of this multi-ethnic microbiome cohort called Helios in Amsterdam.
Yep.
The biggest problem we have is how to define obesity, because if you take a BMI, and you and I have a BMI of 25, then for a Caucasian person that is just overweight, but for an Asian person it's morbidly obese, because they have a different fat storage, they have less muscle, they have more fat in between their muscle. So I think what is obesity is defining first, I think, ethnic differences. And second is, yes, there's very much a genetic driver of that, which goes hand in hand with the ethnic, let's say, burden of obesity. For example, if you have a BMI of 27, you're from African American descent, you have much more muscle than fat, so you overestimate the amount of obesity. And your final question, set point weight, yeah, it seems like when we are adults, when there's this homeostasis, that the body really likes a specific balance of intake and output. That's why you see that changes during menopause and stuff. Those are the major, say, drivers where we gain more weight, or when males start to lose their testosterone. Bariatric surgery can change set point weight. Then you cut not only the intestine, and you cut not only, let's say, the amount of intake that people can do, but you also cut the gut-brain axis. You cut away part of a nervous system. Yep. And that seems to, people have shown, then you can really put a new set point weight there.
That's interesting. So does that explain this concept of kind of yo-yo?
Yeah, exactly. I wrote it in the book as well. That's exactly what it does. The body has a memory for how much fat cells it wants to have. Yeah.
And does that mean that the only ways of truly changing that are through surgery or invasive?
Yeah. You need a reset, and the reset cannot be done by these medications, which we're going to talk about later, like the incretins and stuff. If you stop them, people bounce back. So, and that's also why diets are so difficult.
Yeah.
Because the diets are very hard to maintain. They only give 5% body weight loss. So the bariatric surgery is the best intervention we have, but the side effects are also there. Like basically you're cutting the wire between the brain and the gut, but the gut is still programmed to absorb and to please the brain. So when people after bariatric surgery, they have like a twofold risk of becoming gambling or sex addict or alcohol addiction. So there is major things that
after the procedure.
Yeah. So they cannot eat anymore. But then what you see is that there's a change, that this connection of reward is going towards different directions.
Wow.
Yeah.
That's fascinating.
It's fascinating. But it also tells us where we developed, just like with the FMT, we developed bariatric surgery in the 1970s, not for this reason. It was a surgery to cut the stomach and get rid of ulcers. And then suddenly we saw a bariatric effect, so a weight-losing effect. But then 50 years later, we see that it really works well, but there's never a free ride, James.
No,
also not with the FMT. There's always a side effect. And that's why we have to be cautious when doing these FMT interventions. I've always been advocating really monitor very well what you're doing, because you never know whether there will be a 10 years longer effect.
That makes complete sense. Before we move on to kind of body weight more generally and all these new interventions, could you just maybe walk the listeners through your work in the FMT space and how that's progressed, and what are you excited about looking forwards now into the future?
Yeah, so the first thing is that we, until 4 years ago, always did fresh FMT. So what we basically did is we asked donors, people that would give their feces, their stool, to us to come in the morning and provide it freshly. So that was a huge logistic operation because people would get sick. We had to cancel or postpone the intervention. They would come. We would mix the solution and then bring it into patients who had their bowel cleaned via duodenal tube, and then flush the donor stool or their own stool through this tube, and basically give the intestine a new wallpaper. That is how we did it. And I'm an endocrinologist, so we stayed on my field, an internist. So we started with C. diff because of the reason I just told you, the Googling kind of experience. And there we saw that it was really effective. We've never seen such an effect.
No.
And then went to obesity type 1 and type 1 diabetes, which is the autoimmune form of diabetes, and fatty liver disease. And
Max, sorry, can I just stop you 1 second?
Yeah, sure.
Just to ask a question. When we talk about seeing such an effect, I think we're talking about sort of
90% cure. 90% cure. I'm also proud that study, together with a follow-up study that showed exactly the same by another group, made this FMT come into guidelines.
Did.
And for a study that costed $500,000. That's it. So this changed.
Seminal. It is.
It was seminal. It was. Yep. We will never see this again, and we still also don't understand how it works, because you see that there's a desert in the gut of patient with Clostridium, which is really diarrhea. You come in with healthy donor stool. Suddenly the complaints are gone, but the bacteria that cause the disease is still there in very low amounts. How does this work? We have no idea, but it works.
Do you think we might be able to get to that level of efficacy with the right patient selection, maybe the right microbes, or is that really just a one-off? Like, how optimistic are you on
for C. diff or in general?
Beyond C. diff, like for metabolic syndrome, like for IBD.
Yeah, I think for IBD and the other autoimmune disease, type 1 diabetes, we will get there. So we will find the patients on their HLA like subtype and something like that, where we can look at their genes and say, you are the person that can get the FMT and make it work. So we'll be stratifying, as it's called, patients. Even though you have the same disease, we're going to look a little bit, what is your genetic background, what is the marker in your blood, and then you will very highly likely have an effect of the FMT. My biggest hopes are for cancer, because in cancer, we all know that there's new medication on the block for already 8 years. It's called checkpoint inhibitors. Yep. And these checkpoint inhibitors have major effect on the biome, but also on the endocrine system. So and that is in most patients. So I think cancer is a problem not only of that the medication at a certain stage stopped working and your tumor is growing despite that you're giving cancer therapy, but the other thing is that people usually lose weight. They get anorexia or cachexia because of the cancer, and that is probably coming from the gut. So my idea is that I'm very hopeful that if we find the right patient subgroups for autoimmune diseases and cancer, we can do something with first FMT and then find bacteria, but it's never one. So that I'm telling you that. I thought so, but it's never one strain. That's arrogant of scientists and me to think that one reductionist approach could work. It doesn't work like that. You need strains to work together. So you need an army of bacteria.
Yeah, got you. So maybe another aspect to your evolution of thinking was it started with a single strain, but now it's more consortia based, maybe even FMT. FMT is still the best in your opinion?
Now it's still the best because this is the natural ecosystem that you put in. Yeah. I think as we go along, we better understand which bacterial strains help each other, like an ecosystem of the forest. But the FMT also has viruses in there and other stuff that we still cannot give. So by now, FMT, when it's safe and fine and well screened, I think it's our gold standard for the next 10 to 20 years.
Wow, that's awesome. 20 years is a long time, and we're moving really quickly, right? But look at the progress we made in the last 17 years. So, so I'd love to pick your brains then on what's the optimal diet for the microbiome, but also if you could also contextualize it, put an obesity wrapper over it as well, seeing as you're an expert there as well. Do we know what the best diet is?
Also here, I have to answer this question in two ways. One is there is a regional and ethnic difference, that's for sure.
Yep.
But the second is, it depends on what is still in your microbiome. So I think a US is a good example there. You know, this is the work of Marty Blazer, 30% loss of bacterial strains compared to people in the Amazon. That is true. And we see that 30% loss is maybe not as big in Europe or in China, but it's getting close, but it's different strains. So apparently,
interesting.
we're losing different strains that are important for us. And it's like a house of cards. At a certain stage, it starts wobbling and it just falls apart. So bearing in mind that we have lost a lot of strains that are not coming back with a diet because they're gone, right? So you can give a healthy diet a lot of fibers, but if you lack many of the bacteria that can make out of these fibers beneficial stuff like a short-chain fatty acid butyrate or whatever, you can throw in as many fibers as you want, but the bacteria cannot really do a lot with that because they don't have the tools. So my idea is when you're healthy and assuming that your microbiome is at a critical level, a good level, not a critical level, a good level of diversity, which means many strains that help each other, then a high fiber, a low fructose glucose diet, low carb diet would be the best for everybody. But as soon as you're going into, let's say, a person from the US that is used to drink a lot of soft drinks and a lot of high fats, killed many of his bacteria or her bacteria that are able to process fibers from vegetables or whatever, then you cannot do much benefit anymore because the microbiome cannot handle that. And it will not, it is not that if you start eating healthy, that missing bacteria are coming back by its own. So that's why I think it's called the CRAF Foundation. They're based in London. But it's also Jeffrey Martin Blazer's work that he says at a certain stage, and it is what we just discussed, you have to reintroduce strains to build up a new ecosystem. And that can be done preferably by next generation probiotics, or if it's really that bad, an FMT. But that is needed. And there's beautiful work done by an Israeli group, and Karine Clement was also there, where they gave a beneficial diet to people who were obese in Israel, gave that diet for 3 months. At the end of 3 months, collected their stool. It's the Renaud paper in Gastro, I think 2020 or something. So they gave them 3 months healthy diet. Then at the end of the 3 months, they stopped the diet but collected the stool, make capsules out of it, and gave that for another couple of months to the volunteers. And they saw that the beneficial effect of the diet on less diabetes, less inflammation was continued while stopping the diet, just because you gave every day the bacteria.
I love that.
So I think we still have to...
That's proof of concept for the microbiomes.
I agree. So I think, yes, it's there, but we need a critical mass of bacteria to do the job. And that is, I think, the connotation I have to make. So you need to screen a patient before you start the diet.
That makes sense. That makes complete sense. And then sort of just taking that a step further then, when you talk about next generation probiotics, can you walk the listener through what they are versus what they might be able to buy at the moment in, whatever supermarket they choose to frequent?
So most probiotics that we have now, that we had a couple of years ago, were the lactobacilli,
the bifidose.
They were coming from dairy products. Usually they're not all of them coming from the human gut, except for the E. coli Nissel. And these strains, they have health claims. When you do meta-analysis, they don't really work. They give you 1 day shorter of traveler's diarrhea or antibiotic-induced diarrhea. And I think it is because they usually don't reside in our gut. So it's beautiful work, I think, by Paul O'Toole and others, that if you give these probiotics and you stop, there's only a fraction that is there after a week or two after stopping. So these probiotics are nice, but they're not endogenous. They don't really normally find out our gut. So then the next step is the next generation probiotics. So Akkermansia is one of those strains that is now commercially available. But here I think we should realize that there are some companies that brought probiotic strains, but a strain has a role in the ecosystem. And I think Akkermansia is a strain that is not a very causal strain. It's just at the end of the food chain of the bacteria. It's the thermometer of a healthy gut. So what you also see when you introduce it, it's you do something on gut health, but not much on weight, not much on inflammation. So I think where we're going is that we have specific strains that are needed to build diversity again, as we were just saying. And those might be, I published a paper in Cell Metabolism, a position paper on this. It probably is like D. piger or something like that, a strain that is not available yet. But if we give that, you know that it in animals, it can make a bacterial society bloom. So it gives room for others. Then you have the next is, for example, a Fecal prosnitzi that makes a lot of butyrate, and that makes, let's say, gives enough fuel for other bacteria to grow out in magnitudes. And then the Akkermansia comes at the end. It's just monitoring if the gut is healthy, and if it's gone, then you know that there's not a lot of food for the bacteria anymore, because they usually feast on what is coming from the diet, but mostly from the mucus layer, which we just discussed. The mucus layer is the sugar layer that the intestinal cells make to make our stool pass, basically. So I think that in the next few years, it's going to be exciting because these probiotics will come on the market.
Yep.
It's a single strain. They don't do a lot. They're also harmless, but they don't. But if you start combining them, they might have real synergy.
That's
and
interesting.
that's going to be exciting to see what's coming out there in terms of a synthetic combination. Yeah.
One that's actually meant for the human gut rather than being in cheese or
exactly,
yogurt.
Exactly. And these single strains, they do something, but we can do much more. It can be much more powerful.
Yeah.
And I think by combining, we're going to see it, but also to first know in a patient's stool, so what is happening there? What is happening? What is missing? Because now you're just throwing in stuff in a black box, just like we did with the FMT, but it can be better.
I'm super excited about the next generation probiotic idea because it's coming.
It's coming, yeah.
It's coming. So tell us then, because it's obviously on everyone's mind, about the GLP-1 story. It's gone crazy. Yeah. I'm sure you get asked every day.
Yeah.
So it'd be great to hear your perspectives on all of this, because it seems, I know several people who are, taking their semaglutide, and it seems to be having an effect. So I'm quite excited. And then I see everything on X and all these platforms, maybe an impact on liver disease, maybe an impact on cravings for alcohol, maybe smoking. Wow. Yeah. So the Novo Nordisk team are probably quite happy at the moment in their boardroom.
I think
so. Yeah, it would be great to hear your expert views on this, like real deep dive.
So these drugs, these GLP-1s, of course, they were discovered already in the 1990s, and it took some time to bring them to the clinic. And what it does is it's a hormone that comes from the gut and from the pancreas, and it basically just lowers your food craving, and it improves your let's say insulin function, so you can better store and burn your energy that you get through the food. So once they were able to bring it by injection into the body and giving it to high dosages, they saw that people were losing weight, and we're talking about 10%. With the GLP-1, and now there's a new compound from Eli Lilly that is a combination of two hormones, including GLP-1 and GIP, and then you can get up to 15 to 20% weight loss. So it's quite effective, but they all do the same. They just make you want to eat less. They help you to synchronize and synergize the other hormones that are involved in insulin and glucose metabolism. And your nausea also dictates that you cannot eat because you feel full. But all of these drugs work via the principle that they just attack obesity. And when you attack obesity, just like with bariatric surgery, when you start losing weight, you will lose your fatty liver, and you will lose your cardiovascular risk, and you will lose your risk of knee problems because they are damaged by your weight. So what you see is a dogma change in medicine, going away from developing medication for a heart attack or liver or kidney or anything like that, but just going for medication that makes you lose weight and keep the weight stable. And I think when we accept that these drugs give you now 10, 15, 20% weight loss, which if you weigh 120 kilo, you could go up to 90 or 95 kilos. But what they're going for is medication that can bring you back to 70 kilos, just like bariatric surgery can. And then, well,
and is that possible?
Yes, I think it's possible with medication, because we have many other hormones that we can focus on and bring into supraphysiological levels, because that's what we're doing. We're just giving it in very high quantities to the body. And apparently the body can handle it. And the benefit is you lose weight. But the thing is, if you stop the medication, you'll bounce back. So that's what it is. So it's also good for the pharmaceutical company, because you have to use this lifelong. It will probably not work to taper people, so to stop it at a certain stage. Lifestyle is still important. And I think we learned from bariatric surgery a very important thing. Even if you do a reset, which we just talked about, after a couple of years, people start gaining weight again. And I'm not surprised that this set point weight is also turning its head around the corner with these medications, so that at a certain stage, people will 5 years, 6 years after using it, they will slowly increase again with their body weight. So they're not miracle drugs, but the thing is, many pharma is now combining all these different hormones into drugs. And we'll come into an era where people are gonna lose, let's say, 20 to 30% of their weight. And if you would combine it with the bariatric surgery, for example, you would maybe be able to lose the half of the weight.
Wow.
At an expense.
And that expense, going back to your earlier comment, there's not a free ride.
No, so you see that in obese people, the brain is differently wired. We all know that if you eat some sugar or a Coca-Cola or some kind of candy bar, it really gives you a rush. And this is the same what you see with alcohol, for example. And the brain is wired for that. That is the way we are built. So, and the brain still wants that, right? So my idea is that, yes, we will see less obesity, but especially with the bariatric surgery, we see what happens if you do massive weight loss. There's other diseases coming by, and we just have a trade-off. But it doesn't mean it's bad, right? I think obesity is a major non-communicable disease, health issue with cancer increased, heart attack increased, but also quality of life and joint disease and whatever. So very important we do something about it, but we haven't tapped the potential of the biome in this. We know that the biome can produce GLP-1 itself as well. Yeah, it's a yin and yang in the gut. Dictating how much the body itself produces. So I think we start to tap on that. Maybe we find more subtle ways of affecting weight while not having this brain kind of effects on addiction. So what's your vision for the microbiome in this GLP-1 story? Is there a role here? Yeah, I think there is a role, but not by this. The way I see it now, and I forgot, of course, the name of the authors, but it's a Cell paper last year, I think, where they showed that the GLP-1 can be produced in very tiny amounts by the microbiome itself as a single ligand molecule. So I think if we can get our hands on those molecules, we will understand how they talk with the body, because apparently the microbes can give them signals very locally in the gut to the pancreas, but probably also via the blood into specific parts of the brain or the liver. So I think the pot of gold at the end of the rainbow will be if we can identify those compounds, make them pharmacological agents, also try to make them into supraphysiological amounts, just like the GLP-1, and start treating patients with it. Yeah. And then you don't have a living bug, but you're using a product of a bacteria that you magnify in terms of quantities and then put in the body. And I think that's where we're starting now. And I've seen very interesting, let's say, first data on that. So that brings me to a question that one of my team had for you, which was around the best donor for an FMT. So how should we be selecting our donors? Are they vegan? Are they low body weight? Or maybe just to pose a thought experiment to you, are we better finding somebody whose parents are both massively obese, but they're
very, very slim and athletic, because it could be their microbiome.
So this is a very interesting question. I will start with the last, so the obese. So we published it in 2020 in Gut. We did an experiment where we had the idea, is the stool of one obese subject who was insulin resistant, if you give that to another person that is insulin resistant, does it do anything? And the thing is, it worsens.
It makes it worse.
It makes it worse. So everybody in that group that got the stool from one obese person, giving it to another obese person, they all worsened in terms of metabolism. So that's ethically not so nice.
But that's interesting. It's proof of concept again.
It's a very interesting concept, and it tells me that there is some kind of key lock kind of thing, even when you are obese. Yeah. So, but on the other end, we showed that people with anorexia, we made a case report on it, but others are investigating it as well. If you give people who are anorexic, so they don't eat because of a psychiatric disease, or cachexic because they have cancer and they don't have the urge to eat, and thus will lose weight. If you give them the stool of obese people, well, in the anorexia patient, they were indeed gaining weight. So as I said before, it's easier to gain weight via the microbiome than to lose weight. And the cancer cachexia trial was very interesting because the weight was stable, but people had a longer survival, 3 months longer survival. So not understood, but so donor effects are there, but it's easier to convey the obese phenotype, so extracting a lot of energy from your diet by the microbiota than vice versa. I also think that those effects are more pertained. They're more long-term, because the other way around, we and others have shown if you have the perfect lean athlete that you put into an obese, there's an effect of 6 to 8 weeks and then the effect is gone. So it's on metabolism. So I think what is the perfect donor is dictated by what kind of disease are you trying to treat with your microbiome.
Yep.
And for C. diff, a healthy donor stool will work, but for anorexia or diseases that are associated with weight loss, and you think the biome could help to get more energy out of the food that you eat, then I think the obese, healthy person would be good. And the lean donor might be very important for bringing back the normal diversity that people might lack.
Gotcha. Yeah. What about the vegan donor or the veggie donor?
Yeah, so we saw that vegan donor had very good effects on specific, let's say, liver disease. We also know that vegan people have less fatty livers, probably because of what they're eating, but we're only scratching the surface there. Yeah. So that is an enigma for me. So we're doing a new trial where we're having vegan donors with giving their stool, and we have capsules and not fresh tube infusion in the gut for fresh feces. So we can give every day a capsule with vegan donor and see if that is better than just 1 or 2 times an infusion. But I think that it just shows that the diet of the donor is very important. And I think it has to do with function, because most of these people have similar high diversity, but the vegans have different function of their microbes. They're not exposed to let's say meat or other stuff where you can make detrimental stuff like TMAO out of from. So I think it's all about function. And for that, well, as you know, we can sequence, but more and more the microbiome field goes into, okay, give me your stool and we're going to culture it and see what it produces in an anaerobic hood. We're also doing that. And we see that it's interesting that different diets can make different production of metabolites. And the best example is we're studying a lot of alcohol production, because we showed that the gut makes, let's say, you and me who are healthy, 1 or 2 beers per day in alcohol from the sugars that we eat.
Every day?
Every day. Every day. It's 1 or 2 beers. That every day is produced by the gut in terms of ethanol, alcohol, and the liver needs to filter that and get away. But in an obese subject,
so that's a baseline. That happens at baseline. Okay,
wow. Every day think about the oil tanker. Every day you're producing it when you eat glucose or fructose, sugar-rich diets. And then the obese person that has the same diet, but the wrong microbes, he or she, half a bottle of whiskey in terms of ethanol. every day. Every day. So every day the liver has to get rid of half a bottle of whiskey produced by your diet
Wow.
because you have the microbes that are fermenting that. So if you start understanding that, then the oil tanker story I started with makes it clear that if you have this day in, day out, the oil tanker will go to the left or will go to the right.
Yeah.
And second is diet is very important because it dictates the function of what your microbiome is producing out of the food that you're eating.
Yeah, to be honest with you, Max, I'm 10 years plus into this field now. That's one of the most impactful concepts I think I've had described across this whole journey so far. Like, it's so clear that, if you've got a bit of genetic predisposition, your diet's wrong, your microbes wrong, if you're getting half a bottle of spirit a day, your liver's going to suffer and your gut barrier is going to suffer.
That's what it does. And it makes you age quicker because alcohol makes your body age. You get more senescent in a way.
Yeah.
So I think if you ask me what is my paper that I'm most proud of, it's this Nature Medicine paper on ethanol production because it shows two things. We have been ignoring majorly the role of the liver in the microbiome field because the liver filters most of these microbiome projects because of not projects but metabolites and products because the portal vein is there. So if the liver doesn't function anymore, you're really screwed.
Yeah.
And the second is the quantities, because I never thought that the microbiome could produce so much, let's say, waste.
Incredible.
But if you think of it, it's not strange. How do we make wine? How do we make beer? We put sugar together with bacteria and we make, at the expense of CO2, we get it. So, and then even the biggest skeptic people are a little bit more silent because then they understand, okay, if it's such a big fermentation reactor in your gut, then we should take much more credit and take much more effort in what we eat and understanding what we eat at a day-to-day basis.
So does this mean then that the ketogenic diet or a super low carb diet is, due to that mechanism, better? Because you often hear this big debate, keto versus carnivore versus vegan versus so.
I don't have the answer. We never studied it. I think the keto diet, I think it's very good to eat as low carbs as you can because we're not made for it. And I always give this example. If we eat too much fructose, and fructose is in candy bars, but it's in Coca-Cola, it's in a lot of food products. If we eat more than a gram per kilogram of body weight, we saturate our own gut that can take it up. It's fermented by the gut and ethanol comes out or other stuff. But fructose, 100 years ago, we would only get from eating an apple, right? Or some orange juice. And you would be filled after eating 2 apples. But now in a smoothie, there's like 5 apples and 3 kiwis. So we're getting huge amount of artificial, but also natural fructose. So if you're asking me, what is a good diet, and is a ketogenic diet which is low in sugar, is that good? I think yes, we do need sugar because the body needs sugar. It's a quick energy source. The bacteria need sugar, but keep it at a certain level. I don't think keto diet is good for everything, especially in diabetics. It can also have major side effects in terms of insulin and stuff. But once again, it is what you present the microbes in terms of food or precursors on the dish. And if you present every day a high carb, high fat diet, the microbiome starts to change towards that because it will select the bacteria that are very good in fermenting and using those food compounds. And what you see mostly is detrimental.
Can I just push you a little bit further on that? So is it possible that if you eat chocolate, French fries, all this kind of stuff every day, your microbiome adapts to sort of preferentially, or not preferentially, but you've been eating that, so more of them appear. Can they then communicate with your brain and say, I want some more somehow through some mechanisms? Is there any work that shows that
we have
it's influencing how you think?
So in animals, it's really shown, and you see that specific tryptophans, short chain fatty acids, ethanol, these kind of compounds, volatile compounds, if they're, most of it is filtered by the liver, but some escape and end up in the brain. And especially near the hypothalamus, there's an interesting part in the brain because we don't have a blood-brain barrier there. So everything that is in the blood can go into the brain there, and it does. So, and the other thing is that, so the microbes talk to the body via their capsules, so via their outside. They can shed stuff that gives inflammation, like endotoxins, but they also produce stuff that is taken up, diffused from the gut into the bloodstream, and then has an effect. And then what we haven't talked about, James, but what I think is the biggest question mark is, we have an equal amount of neuronal mass, so neurons, so nerves, in our gut as we have in our brain. And it's mostly in our small intestine. So why do we have almost a kilogram, just like our brain, of neurons in our small intestine? And why is it connected to our brain? We have no idea.
Good questions.
But we do know that it's there. And well, we played a little bit with this with brain scans. We published it a couple of years ago, where we looked in humans. If you tamper a little bit with the microbiome composition, or you give a lot of butyrate, what happens to specific parts of the brain if you give them radio labeled serotonin, let's say, tracers that are binding to specific parts of the brain, the reward system of the brain? You can see a change. Not as much as in animals, but you do see a change. So there is this interaction. And yes, so I think microbes can dictate, as an oil tanker, very slowly, but every day, a little bit preferences. And if we start understanding that, what do they produce? How do they talk to this vast amount of neurons in our intestine? How do they talk to the liver? Then we would be able, I think, to get the therapeutic agents out, and once again, either reduce them by giving bacteria that are CRISPR-Cas modified so they don't produce it anymore, or giving specific inhibitors that prevent the microbes producing it while doing the rest of their work. That is, I think, what the next generation microbiome research will go to.
That's awesome, because we're running into the last part of the episode, and you know, there's kind of two things I'd like to unpack a little bit more. One is your vision for the future, which you've just started to do there, which is exciting. The other is your book, and we should probably finish on the book. So maybe you can paint a picture for the listener about, as someone who's at the cutting edge of all of this.
So I think it will be two ways. One is, we're already getting to the stage for adults where, at least in some clinics, they're implementing a microbiome profile with all its pros and cons. But that's just sequencing. But if we start combining that with functional tests, okay, you have complaints over irritable bowel or brain fog or whatever. Let's also do a functional test. What is your microbes making of the diet that you eat? Quantifying it, give a personal diet. You can do something, I think. I think the magic of the biome will be in combining it with therapies, like in cancer, where I think FMTs will be implemented together with checkpoint inhibitors, because they're doing crazy studies in the US where people that are responding on these new medication, these checkpoint inhibitors, they take the stool of them and giving them to the patients that have the same medication, but they don't respond. And suddenly they start responding again. So I find that fascinating. So that's going to be therapy. But I think what we're going to do is the microbiome can also help us to predict diseases way before they're there. So, we have these consultation bureaus when you have little children, at least you have them in the Netherlands, I think also in UK, and where you go with your young child and they give you the vaccination, or they check, are you growing well? And I think at that visit, we should check biome. So we could either store stool and then go back when patients start developing an IBD or obesity or type 1, and go back and see if there's a signature in the biome. Because we know that the first few years of life, the biome is not stable, but after that, it's quite stable. Then in puberty, it switches a little bit due to the hormones. But I think, and it's non-invasive, we can just collect it just like urine, and we could use it as a disease predictor, especially for autoimmune diseases and obesity, and intervene much earlier. And that will be personalized medicine. So I think That is what we can do already immediately, but that's just more like governmental epidemiology. Yep. And I think therapy-wise, combining FMT with cancer medication or patients who are not eating very well or losing weight, despite that they want to keep a stable weight, that's FMT. But I think more subtle, can we prevent the bacteria from producing alcohol from sugars in your diet by a specific inhibitor?
That's interesting.
Yeah,
I'm just thinking about how we design a clinical trial, but that is.
I mean, you can.
Cool.
It's just all about understanding the machinery of the microbe, making the inhibitor, which is probably microbial, so it doesn't affect our body because the genes are different. So you make the inhibitor on a specific gene, but it doesn't affect the human gene. You ingest it, it stays in the gut, and every day it inhibits. That is, I think, future. And be aware, statins and antibiotics work exactly like that. It's just a-specific. So we can make it much more specific.
So the statins and the antibiotics
have bactericide effect.
Yeah, gotcha.
But I think it can be more specific because you don't want to wipe out the whole microbiome. You just want to wipe out a function and not a strain.
And the thinking there is because you're probably less likely to be able to change someone from eating lots of fructose.
It's not going to happen. We're living in a
fructose world.
Yes, exactly. So what we have to do is, in the environment where we live, Western world, we have to do damage control on that Western lifestyle. And I think via the microbiome, we can do part of that.
That's cool. Yeah, that's cool. Good. Let's talk about your book.
The book is called The Power of Hormones. It's translated it's now also translated into Chinese and Arab. So why I wrote the book is because I have 15 years of experience in the clinic, a lot of endocrinology and internal medicine, and I wanted to give a overview for layman people. What do hormones do in the course of life when you are born or conceived until you die? So it's 10 chapters where there's also parts on microbiome. Yeah. So what do they do? But it's also very important. I love history and I love the history of science. So I also, for example, brought in a chapter about the first female pope, because at 100 years ago, we were not able to find diseases just after birth, which we do now when we do a little blood test, but we couldn't do that 100 years ago. So if you look at pictures in let's say Italian musea, you see 16th century pictures where there's females with a beard because they have an adrenal gland problem.
Oh, okay.
It's called adrenal gland. And so that was normal at that time. Now we don't see that, fortunately, anymore. But that would also mean that you would have females that looked like males and could have and did have some functions that they were not basically allowed to do. But I also wrote about the discovery of insulin and how it changed life. So I tried to a bit also about my patients. So I tried to give, let's say, an overview of how hormones affect everyday life, how they also affect famous people like John F. Kennedy or George Bush. But also that you're not alone with that hormonal changes are part of life, your puberty, but also your menopause, and that those things are normal in the body to be prepared for a next phase. And that on the side, like on the leash, there's the microbiome walking along with the hormones, producing a little bit of hormones, affecting the function of hormones. So they are. And that insight is so tremendously intriguing because, let's say, in China, 3,000 years ago, but also the old Greek society, 2,000 years ago, they were already experimenting with fecal transplants from lizards or from babies with lizards to give them to people that had a too active thyroid, where you have hyperthyroidism, you're overacting and losing weight.
Hadn't heard this one before.
If you would give...
Did it work? The lizards?
Stool? No, well, it was written down by Aristotle. So I don't think he says that it works. He just says if you have a thyroid problem, use a cold-blooded lizard stool, and maybe it helps you to calm down. That's what he said.
Oh man, so I'd never heard that one before. That's a really good one. Just on the menopause thing, you published with others a paper last year, I think in Nature, about the the machine learning identified differences in sex and menopause in the Helios study. Could you just talk a little bit about that?
You mean in terms of the microbiome?
Yeah.
So the biggest enigma is a little bit, is there a male-female preponderance, right, for microbiome? Especially menopause, where estrogens drop, that then the microbiome of females starts to look more like males. So there is some kind of interaction between the microbiome and the hormones, and that females that are in their menopause and thereafter, they're catching up in terms of more male disease like cardiovascular disease, fatty liver disease. So the microbiome must play some kind of catalyzing role.
Good, Max. We're coming towards the end of our time, so I wanted to thank you very much for coming on and for being generous with your knowledge. If any of the listeners want to follow you, are you active on socials? Where can they buy your book?
Yeah, it's LinkedIn, I think, is the most. I don't have a website. Even I never had time with the lab to do that.
Sure.
So but if you, there's the publisher, it's Simon & Schuster, who published the book in the UK and the US. But they have some interviews. But if you Google, you will find it.
Awesome.
You'll see. Yeah.
Good. Well, thank you very much. Really appreciate you coming on.
My pleasure. And all the best.